So let me begin and welcome everybody from the sponsor and anyone attending outside to this open session. And Marcy, would you like to say a few words of welcome as well?
Oh, yes. Well, first of all, thank those of you who are joining us. We really appreciate your helping us understand the task that we're being asked to do and clarify any issues. I terribly apologize, and I'm going to try to say the least amount. I've had a cough since yesterday, and I can't seem to get rid of it. So why don't you go on and fill it in, because I'm being a little...
Yeah, sure, no problem.
Right now. Yeah.
Yeah, I think if we just go through, we briefly want to have representatives from our sponsoring agencies introduce yourselves. So if you'll just, we'll go around the room, if you'll just state your name and your affiliation. And let's begin with Cindy.
Oh, hi, I'm Cindy Davis. Nice to see all of you. And I do have some opening comments from the sponsors if you want, or I can wait and do that afterwards.
Yeah, we'll do that.
But just to introduce myself, I'm a national program leader for human nutrition at the ARS USDA.
Thank you, Cindy. Amanda?
Hi, everyone. I'm Amanda McFarlane. I'm from Health Canada, and I chair the joint federal DRI working group.
Thank you. Krista?
Hi, everyone. I'm Krista Esslinger with the Office of Nutrition Policy and Promotion at Health Canada, working with Amanda on the Canadian side of this file.
Great. Essie?
Yes, hi, this is Essie Yamini. I'm also part of the DRI Federal Steering, and I'm from US FDA.
Thank you. Sarah?
Hello, everyone. Sarah Gebauer, also with FDA, Center for Food Safety and Applied Nutrition on the steering committee as well.
Thank you. Blakeley?
Yes, good morning, or good afternoon. This is Blakeley Fitzpatrick. I'm with the US FDA and not part of the steering committee, just listening in.
Thank you. And then I see two names. I'm not sure if you're sponsors or not, but you can clarify for us. Hayden?
Hi, everyone. I'm just with the firm, and we deal with the American with Diabetes Association. So just listening in for any recommendations with individuals with chronic conditions from Venn Strategies.
Thank you. And Bridget?
Hello, I'm with Indigenous Services Canada, and I too am just listening in.
Great. Okay, thank you. So at this point, I think what we want to do, I'll turn it back to you, Marcy and John, and you can moderate this open session. Cindy, do you want to begin with your remarks?
Sure. Just on behalf of the sponsors in the Joint Federal Canada-US Dietary Reference Intakes Working Group, I would like to thank everyone for agreeing to serve on this standing committee on the review of the Dietary Reference Intake Framework. As you probably already heard, the purpose of the committee is to provide guidance on how to apply learnings from your meetings to refine the DRI framework through letter reports addressing specific DRI-related questions. Discussions from the sessions on strategic planning for a new review of the macronutrient dietary reference intake values highlighted overarching issues related to DRI concepts that need to be addressed to facilitate a consistent approach for reviewing and setting the macronutrients, future DRI reviews for other nutrients, and DRI-related issues more broadly, including their application. The specific questions to be addressed will be determined both via discussions with the sponsors for various DRI consensus committees, but we expect this to be an open dialogue. And I'd be happy, all of us would be happy to clarify this anymore with questions that you might have.
So thanks, Cindy. This is John. Good to see you again. I just wonder what your major priorities for us are. I know we'll be covering a number of areas, but it would be really outstanding for the committee to know the priorities from the federal side.
So we really didn't want to get into the specifics of the priorities. We have 4 areas that we have highlighted as the top priorities, but we expected this kind of to be a discussion, especially when we also have the meeting with the with you and with the Energy Committee. But kind of 4 of the areas, and it's really kind of open to discussion on which one would come first. But really, they include things like a formalized decision tree on when new systematic reviews are needed, when and which other systematic reviews are of appropriate scientific quality and can be used, an example being the Nordic reviews, and the role of evidence scans and how they fit into determining whether systematic reviews are needed. Another area is reviewing how apparently healthy populations are described, given that much of the population is overweight or obese or has comorbidities. Examining whether the AMDR definition should be modified and the parameters by which the range can be defined and the relevancy of the AMDR. And the 4th area that the group has been talking about is determining if the CDRR model can be applied to non-threshold substances and nutrients or other food systems, or adapted through a range of, adapted to include a range of beneficial or functional intakes. So those are kind of examples of some of the things that we've already identified as potential priorities.
Well, thank you very much. Since the Energy Committee is already underway, I'm presuming that it would be very good for our committee to address items most helpful for the Energy Committee off the top. It's a sort of a question.
No, we completely agree. And I think that's part of the reason why they've scheduled the joint meeting with the sponsors, the Energy Committee and the Standing Committee.
I don't want to dominate the questions, but let me just throw in one more and hopefully other people will jump in. The question of, what is actually healthy? What's a healthy population is a very interesting one. One could argue that there is no healthy population, or there's very little healthy population. Is that something that is kind of front and center?
I think it's definitely one of the priority areas. So I saw in the chat, Nancy asking me to repeat the 4 areas. And
Just your 4th point.
I think that was on the chronic disease risk reduction.
Okay, thanks. That's it.
And going back to one thing that John had asked is about working with the Energy Committee. We definitely do want to work with the standing committees in terms of what their issues are. And that's why in our request to NASM, we requested that there be a liaison between the energy that would be on both committees. And that's part of the role that we're hoping that that Beth would serve.
Yes.
Sorry. I'm sorry about that, Beth.
I have a question. It's those 4 areas that you outlined, and I suspect there may be a few more, are pretty overarching. And I'm just wondering, do you envision any temporal related issues with the Energy Committee sort of getting started before this committee, or even working concurrently?
So the answer is, like, one of the issues, the AMDR is not as relevant to the Energy Committee. It's something that definitely is, would be something that would probably be taken up in the future, just because it doesn't have as much relevance. I think part of it is thinking about what is going to be most informative for all of the reviews going forward, and what is going to make the time for the different committees be as effective as possible. But I'm doing all the speaking. If other sponsors want to jump in, please feel free.
Well, it certainly makes sense, but because one of the issues you brought up is the CDRR, and I was on the committee that sort of proposed that with the sodium potassium, and one of the issues that came up and was never really resolved is that more relevant than the macronutrient distribution range, or sort of what categories do we need, what categories maybe we don't need as much in the 21st century as we needed in the 20th century.
One thing that I should highlight is that we're actually looking forward to discussing and prioritizing with you. We're not, I mean, yes, we will be somewhat prescriptive, but we really want it to be a communication.
We have other questions from either side. Now's really the time to get anything clarified. Love to hear from Health Canada if we could.
Sure. Again, I think Cindy summarized kind of the priority areas very well. And as a working group, these are things that we work through together. And I think as we move forward with these kinds of discussions, like Cindy was saying, it's really a matter of prioritizing. All of these topics are of interest. They're all important. All of them, to some degree, will have some impact on the ongoing macronutrient review. And so I think when we're thinking about prioritization, maybe we talk about, what's the highest level that's going to impact most of the work going forward. And maybe that would be a way of starting to think about which topics would go first. So definition of a healthy population, that probably affects all the committees. It's also a big, meaty topic, so that, I think you can see where that might be important. And like Cindy said, the AMDR, maybe that's something that can come later, because we don't have those individual macronutrient reviews going yet, and we can think about that, as we go forward. So these are the kinds of considerations that we're looking to you, the standing committee, to help inform, kind of that order as we move forward for these letters.
Very helpful.
John, it's Stephanie Atkinson. I did put my hand up. Maybe you can't see it.
No, go ahead.
So this healthy population definition, I think it's really foundational. It's a paradigm shift if you're going to go away from it. Our nutrient intake for decades have been based on healthy population. So if this is something that all the members of the sponsors really want considered, then I think that they have to be ready to change the foundation of what nutrient requirements have been in the past. And we've got to sort that out before we can go anywhere, I think.
Yeah, Stephanie, you make a really good point. And I think the other thing about the apparently healthy population, maybe that's the goal. And again, this is just brainstorming here. Maybe that's a goal of where the DRIs would apply. But a lot of the evidence we have is in non-healthy populations. So how do we use that? How do we apply that for the healthy population? Our populations on both sides of the border have lots of comorbidities included in a large proportion of the population. So how does that definition, how can it be generalizable? These are, the definition aside, it's really, what do we do with the evidence we have? How does it apply to that definition of an apparently healthy population, as well as the reality of populations that maybe have these comorbidities? And so, I wouldn't get, the definition is important, but maybe let's not get hung up on that. It's really kind of the evidence that we have in the population. So how do we incorporate that into the DRI framework?
Yeah, I mean, there's clearly overabundance of research on those who already have the comorbidity or have a disease, and looking at a therapeutic effectiveness of whatever, diet, exercise. So it's, I think, as you said, it's how to handle the integration of the information from more or less healthy people with the disease morbidity people. It's not just this forum. I've had this discussion. It's in other forums, both internationally. I don't know. I think that's a really major step that we have to come to terms with before we can move forward. I see Alice's hand is up.
Yeah, I agree with you. And I think what we need to take into consideration is, are we making recommendations for a minority of the population or the majority of the population? And I've also sort of been privy to some of the conversations about trying to define healthy, but I think we also need to take, or at least consider, what the current public health situation is now, what it's been for the past, let's say, 3 or 4 decades at least, and what really we want to accomplish, or what the sponsors want the DRIs to actually accomplish.
I think it's interesting, at least I'm thinking about this, that for a lot of vitamins and minerals, those studies were done on, quote, healthy populations because they were asked to do that. Yet our chronic disease endpoints, says we look at lipids, proteins, carbohydrates, fiber. A lot of those studies, as pointed out before, are largely done on unhealthy populations. So I don't know if there's a line there where we've got a lot of data, say on vitamin C, which came out of NIH, or compared to coronary heart disease endpoints, where we change types of lipids.
Well, there's also the issue for something like vitamin D, which, and I'm not an expert on vitamin D, but my understanding is a certain amount of it can be sequestered in adipose tissue. And if the majority of individuals have excess adipose tissue, does that need to be taken into consideration? So those kinds of issues also. And should there be the same nutrient recommendation for a 300-pound male and a 95-pound female, or vice versa? But you get the gist of it.
I think
Yes.
Amy had her hand up, and then I had mine up.
Okay, Amy.
Yes, I was just going to ask a naive statistical question, and that's, how well is apparently healthy characterized in terms of the populations of the US and Canada, and how does that break down across factors like age or race or other sociodemographics?
That's a great question. And off the top of my head, I would say that we've mostly just deferred defining it. I know the work that I did with the options report for using chronic disease outcomes for the DRIs, it was something that we grappled with initially, and then we're like, we'll leave this to another day because it's too difficult. But that's my experience, but I don't know about others on the call.
Yeah, this is Beth. There has been some discussion in the past that the defined population to which the DRIs applied should be the majority of the population. And if you follow that guideline, it seems to me that you'd have a different definition of the covered population for each nutrient. Whereas if you define it the same across all nutrients, then it becomes a constant. So I guess what are your thoughts on whether or not you want consistency across all nutrients, or you want a definition that is more relevant to the nutrient under discussion?
This is something that we're going to have to discuss when we have all the sponsors here. Pretty much we are missing some of the other key members of the committee, and we wanted this to be much more just of a general overview rather than getting into the specifics of specific questions and how we would go about them. Sorry, not to, I mean, you're bringing up very, very important questions for thinking about how to go about it, and you can understand, and it highlights why this committee is needed and the type of things that you can start grappling with.
Cindy, other sponsors, do you want to talk a little bit about what you're looking at in terms of the reports back from the committee? What kind of things are you looking for?
I think that we're looking for recommendations in terms of different approaches that could be taken and what the strengths and limitations are so that we can make decisions about the best way to go forward when we do contracts going forward in terms of other CRIs, and communication with the standing committees to address their needs. But I'll see if somebody else wants to respond.
I'll just say, I think in terms of the letter reports, we're looking to formalize some of the things that have been kind of in the purview of the DRI framework, but perhaps haven't been established. And Cindy had mentioned one of the questions we had was, you know, when is a systematic review that's been done by another party, not sponsored by the federal working group, when can that be used? Is there a way that we can formalize that in the process? Because it's, you know, systematic reviews are very resource intensive, they're very expensive, and we don't want to duplicate work that's already been done, but we also need to formalize the approach to identifying kind of qualified systematic reviews. So that in terms of, that's just an example, but in terms of the letter reports, we are looking for a little bit of formalizing some of the approaches that it can be incorporated to the DRI framework as it moves forward.
Expand on that some. Does that mean that in the past the DRI panels were not allowed to use systematic reviews that were not commissioned by the group?
So the two, the calcium and vitamin D and the sodium potassium did brand new systematic reviews for their committee. The Nordic countries have recently done a lot of systematic reviews to inform their recommendations, both for foods and specific nutrients. If they've recently done these, are they appropriate to be considered in the U.S. systematic reviews or not? What qualities? What would be a high enough? What would be a high enough scientific quality? If there are places where some of the questions have already been asked, and we could avoid the cost of duplicating that, it's great. If you don't feel that it's appropriate because there might be differences between the populations, then that's important to know too.
Thanks. That's an important question, and I know the cost of these are very, very high. Yeah.
Yeah, and to answer your question as well a little further, so that, you know, the feds have always, in the last 2 reviews, submitted a systematic review, but those systematic reviews are also on particular topics, and the committees are able and do evidence reviews and searches on their own. So again, we just want to formalize the process of how, you know, if there are other systematic reviews in the literature, how they would be selected and used and deemed of a high enough quality for them to be incorporated into it.
Oh, good question.
And again, if there's things that we can do to decrease the cost of doing each nutrient or macronutrient, then it makes more funds available to do more of these. In an ideal world, you'd have updated DRIs for all the nutrients and even maybe some of the bioactives. It's not feasible given the current level of funding. So we want the best scientific quality, but at the same point, we want to minimize the cost if it's possible.
So just to make a note, Marcy lost her connection, so that's fine. I'm kind of running, I guess, one good reason to have a vice chair. I have another sort of clarification. So I know Beth Yetley is on the standing committee as well as the energy committee. And are there some bounds in which we can discuss things with Beth as far as what the committee is doing?
So I'll let Ann, but as far as we're concerned, this committee, anything that this committee is doing can be discussed with the energy committee. I think the bounds are more on the other side.
Right. So a committee member cannot disclose deliberations or other information discussed in closed session. And I think the way we envisioned the liaison for this committee was someone who had knowledge from both sides that could help inform and guide the standing committee in its work, but not, of course, to report exactly what the energy committee was talking about, but to provide insight and guidance to help the standing committee in its response to questions from the sponsoring agencies.
Just so you know, Ann, I am able to hear.
Mm-hmm. Okay.
So thank you very much, John, but I think it would be best if you do continue because I may disappear again too.
Yes.
I'll try to get this fixed. I don't know what the problem is.
John, can I just
Please
say something? Well, first of all, as far as evaluating the systematic reviews, there is a PRISMA system that has been established. Not adequate, Cindy?
We're not talking, a lot of what's been published follows the PRISMA guidelines. We're talking about when it's relevant to
I see.
think
Okay.
about.
And that will also go back to the population, the definition of healthy population. I'm just wondering from the sponsors, I mean, my first introduction to our DRIs essentially were in the 90s when there was the radical redesign going from RDAs to DRIs. And it seems like with some of the issues that have come up, it may be from a public health perspective that there may be, I mean, would you envision there to be a reassessment of the whole system, or is your view more to work within the current framework?
I think we were thinking of staying within the current framework and improving it, but if there's a strong rationale or a good reason to redesign the system, we'd like to hear that. I don't think we're married to one thing or the other. We're married to, as science evolves, the way we look at things evolves, the population changes. How do we make the DRIs as relevant as possible based on the best scientific evidence and to be as useful as they can be? Maybe Janet, you have something to say. You're shaking your head.
Sorry, I was double muted. No, I was just agreeing with you because I think where we are in the situation with public health, that, you know, we'd love to hear from the committee if you have thoughts on changes. So overall, and we've wrestled with this, you know, from the federal side. We've had a lot of discussion about what diseases to include, you know, in the scope of work, even for the energy committee that's already started. So, and we wanted to hear from them, you know, what evidence was relevant on these different outcomes that could improve the DRI. So that could be a very good, helpful discussion. It's a good question, Alice.
I would like to put in, I don't know that we need to throw the baby out with the bathwater. It's the one thing. And we probably need some guardrails before we start saying we're going to revamp the entire framework. For instance, some of the fundamental aspects of the DRIs are primary prevention and not treatment and not clinical, these are not clinical guidelines. So there's some fundamental aspects of the DRI framework that I think need to stay in place.
I think that's really helpful, and it'd be great if, as a group, we could come up with those things as we move forward.
Yeah.
As you say that, then a lot of the things, and Beth has been a co-author on some of these papers, and there's a consideration of chronic disease, of DRIs for chronic disease. So that certainly could be primary or secondary prevention, I would think.
I think
yeah, we completely agree.
Yeah, well,
Go ahead, Amanda.
I think we need some more discussion on that, because I agree there can be primary and secondary prevention, but again, I think there would need to be discussion about how that impacts the framework for the DRIs and what the DRIs would need. And so the chronic disease principles are really about risk reduction, not treatment. I think we want to clarify exactly where you're going with that.
In some cases, it might be the same. Risk reduction would be risk reduction for both. I'm thinking lipids here particularly, which is more Alice's line than mine, but.
Yeah, I mean, I would think since these, the guidelines are for the entire lifespan, it would be great if we got rid of all secondary prevention. We could only do, all we had to do was primary prevention, but yeah, those kinds of things will have to be addressed.
That's part of why one of the priority areas is a better refinement of what's meant with the CDRR model.
Mm-hmm. Oh, there are other hands up. I don't see everybody right offhand, but that's good. So, Anne, when we meet with the Energy Committee, that's an open session, is that correct?
Mm-hmm.
And
yes.
So
Mm-hmm.
I hope some of the federal committee members will also be on that. Is that correct?
Yes. It's a session for this standing committee to meet with the Federal DRI Steering Committee and the DRI for Energy Committee. And that's where you may have more in-depth discussions about potential questions and, specifics about what the committee might want to take up. But here we want to make sure that you, as members of the standing committee, are clear on what you're being asked to do and how you would be carrying out your charge. If nobody else has a question, I'd like a little more clarity. I think you mentioned early on in your priority areas a decision tree. Can you explain what you had envisioned for that activity?
Well, again, I'd like to discuss it with the group more in depth before we do it, but it's more when systematic reviews might be appropriate, and a clear way of thinking of what other ones might be appropriate or not appropriate. If scanning reviews are done beforehand, when should they lead to full systematic reviews?
Okay, thank you.
other questions from either side or comments?
Other than that, it looks like we have quite a bit of work to do on the objectives.
Well, if there aren't, I want to personally thank the Federal Steering Committee for appointing a standing committee of this sort. As you all know, we had one for about 10 years when the DRIs were being promulgated. It was very, very useful, I think, for making sure that the committees kind of all spoke from the same hymnal, so to speak, and with the same guidelines. So I think this will help a great deal. And I know that requires resources on your behalf, but thank you for doing this. I think it makes a whole lot of sense, and hopefully we'll be providing letter reports that are very helpful for you and also for the committees going forward. Last chance. We can. Ann, anything from your side?
No, I will mention that I neglected to have the committee members introduce themselves to the sponsor. If you want to do that really quickly, that will allow you to put names and faces together. Shall we do that?
Yes, for sure. Well, I can start. John Erdman, I'm a professor emeritus, food science, human nutrition at the University of Illinois Urbana-Champaign. And Marcy, you're still on?
Yes, no, I'm on. I can hear. I'm just afraid to try to switch to video because every time I do, I lose the connection. So anyhow, I'm Marcy Greenwood. I'm also professor emerita. I'm here at UC Davis with the nutrition department. And I'm also president emerita of the University of Hawaii, and I have some other affiliations like that. But my current one is with the University of California in the nutrition department, and I live here in Davis. So I'm very pleased to be re-engaging in these issues with some of you, and there's so many of you I don't think I've ever known or met before. So this will be hopefully a good experience for all of us. And I promise, Ann, I will do my best not to have a computer gremlin at our next meeting, but there's not anything much I can do because I'm home.
Yeah, no worries. Okay, Stephanie?
Hi, Stephanie Atkinson, a professor of pediatrics and biochemistry at McMaster University. That's in Canada, Hamilton.
Amy?
Hello, I'm Amy Herring. I'm the Sarah and Charles Ayers Professor of Statistical Science at Duke University.
Nancy?
Hi, I'm Nancy Krebs at University of Colorado in the Department of Pediatrics, and I'm a professor of pediatrics and section head or division head for the pediatric nutrition.
Great, thank you. Alice?
Hi, Tufts University. I'm the Groschoff Professor of Nutrition Science and Policy at Tufts University and Director of the Cardiovascular Nutrition Laboratory at the Jean Mayer USDA Nutrition Research Center on Aging at Tufts University that is under Cindy.
Very good. Thank you. Nadine? Alice, do you want to introduce Nadine?
Sure, I'm just speaking for Nadine today. She is professor of nutritional epidemiology at the University of Maryland, College Park.
Thank you. Valerie?
I'm Valerie Tarasek. I'm a professor in nutritional sciences at the University of Toronto.
Thank you. Beth?
Beth Yetley, retired from NIH.
Great. And I will mention there are two committee members not present with us today. They are, first of all, Sai Krupa Das. She's a scientist in the Energy Metabolism Laboratory, also at the Jean Mayer USDA Human Nutrition Research Center on Aging, and at the Friedman School of Nutrition Science and Policy at Tufts University. Also not with us today is Linda Van Horn, who is professor and chief of the Nutrition Division in the Department of Preventive Medicine at the Feinberg School of Medicine at Northwestern University. And I don't think, have I left anyone out?
So,
Well, if they're not here, they're not going to speak.
Right.
well, if there aren't any other questions at this time, we can give our federal steering committee a couple more minutes back of their time. So thank you again, and you'll be certainly hearing from us, and we'll be hearing from you. So thank you.
Thank you, everybody.
Thank you so much. Bye.
Mhm.